Good morning, good afternoon, my friends. First of all, I would like to thank Dr. Farouk for his invitation. And sorry that I couldn't attend my in person because of the busy time, and also I'm involved in another event in the same day. Great greeting to my all my friends in the World Federation of the Spine Endoscope, and my talk today about posterior cervical endoscope discectomy will replace the ACDF, which is the gold standard. First of all, nothing to disclose in my talk, and this is my picture in Pakistan, Lahore, where I did the first UBE surgery there without using any sophisticated instruments. I used the basic spine sets, and I finished the surgery with using the scope for knee and the RF for the shoulder, which give us a great clue and about the feasibility of this technique, and also that we can do even in the limited resources that you have. I will start my talk with the case presentation, who's a 37-year-old male, left side radiculopathy associated with paresthesia in the last 3 months, mild neck pain, and he's a musician and looking for the solution for his condition. This is his MRI, and sorry that could be not good quality, but this is what I have, which show that C6-7 posterolateral toward the foramen, left side disc herniation. And this is his CT scan, which show that's fresh disc without any calcification. We will discuss the treatment plan according to the available options as seen here, that ranging between from conservative ACDF, TDR, laminectomy, posterior tubular discectomy, or posterior endoscopic discectomy, or any other technique that you suggest. Learning objective, my talk will be introduction, presentation, diagnosis and treatment plan, and also case solution for the case that's presented. So let's dive. First of all, we have to define the cervical radiculopathy as a pain or a sensory motor deficient syndrome that is defined to be caused by compression of the nerve root. This is talking about the cervical radiculopathy. And this compression could be either result from disc herniation, spondylosis, instability, trauma, tumor, or any other factor or causes. And also the presenting symptom, it's some sort of the pain that's with the distribution. The dermatome, according to the affected nerve root, could be numbness or tingling in the upper extremity, electrical-like pain, or even in advanced cases or presented with a weakness. The neck pain might be present or not, which is not a cornerstone symptom in this condition. Clinical examination, we have many tests: splenic test, Valsalva maneuver, shoulder abduction, upper limb tension test, neck distraction, range of motion. These are all signs that could be present in the patient presented with a cervical radiculopathy. And these are the let's say the reflexes and the muscle involved according to the cervical dermatome, and I know that's all of you know it. Imaging, we have to start with the X-ray apilateral and the dynamic in some condition when the patient tolerate that. CT scan is in special condition that we have to look for any osteophyte, calcified disc, opal, and MRI, which is the cornerstone for diagnosis. And we have two types of MRI, either static or dynamic, and EMG and nerve conduction study. When we start with the MRI, we have many options. I routinely do the dynamic MRI because I saw that it could add some data over the static. And I'm also interested with what's called oblique sagittal MRI. because the C-spine oriented in the nearly 45-degree oblique position, and the traditional cervical sagittal does not offer a clear view for the foramen. So this is the study that's done, which show that the foraminal stenosis grade, which is done by Park et al. In 2013, they saw that they grade the foraminal stenosis into 4 grades from 0 to 3. EMG by itself relatively poor predict the capacity to showing the nerve root compression, and in the study they saw that only 42 patients with a positive EMG find has a compression at the time of the surgery, while 93% with a positive MRI finding the pathology. So alone it's a poor, while with MRI give a good percentage of accuracy. And also you use as a supplement for diagnosis when the diagnosis is vague, and also to exclude the other causes like peripheral neuropathy, or due to the, let's say, diabetic or any other conditions. Conservative treatment is the key, and it's successful in most 75 to 90%. Analgesia, muscle relaxant, hot pad, traction, it's a questionable whether it's get benefit or not. Color, and also there is no solid data supported. Manipulation, I don't have any experience whether you have or not. And also local injection could be solve a problem in some cases. This is my surgical algorithm to treat the disc when the disc is calcified, central or posterolateral. If yes, so with a significant radiculopathy, no instability, and also young, let's say young age, we can go with a TDR. While if it is not, let's say, associated with significant neck pain, there are some sort of spondylosis or instability, elderly age, I will prefer the ACDF. While if the disc is lateral disc fresh with unilateral septums, definitely I will recommend the posterior endoscopic cervical discectomy, whether by uniportal or biportal. ACDF, as we know, that is a gold standard for cervical disc. It's offered direct and indirect decompression by the cage, address bilateral foramen and central disc, preserve the lordosis, and also with high fusion rate, more than 90% in most of the study. And this is the outcome that they show that's the offer the foraminal dimension in the patient with foraminal stenosis after the ACDF. This is the study. They show that the disc height are increased from 4.75 millim to 7 millim, and also the foramen from 7 to 9, which is give us the strong conclusion that this technique will work. And also it's also preserved the lordosis, as we see here in this study. The conclusion of this paper, they conclude that, let's say, ACDF in cervical stenosis as a useful surgical option to improve the clinical outcome and widen the foramen dimension. And also the foraminal dimension was negatively correlated with the pain. And restoration of the posterior disc height was necessary to widen the foraminal dimension, whereas increasing the lordosis and diffusion segment did not help to widen the foraminal dimension. This is a very important point to be mentioned in this paper. So when we go to the ACDF versus anterior cervical foraminectomy, insertion of the graft will increase the rate of fusion, increase the degree of post-operative lordosis, indirect decompression by increasing the disc height with a cage, as I mentioned, and also allow to predict the outcome with the relief of symptoms up to 90% in the patient with radiculopathy, and the preservation of motion segment in anterior cervical foraminectomy in patient with only unilateral septum. Surgical option for posterior cervical foraminectomy could be either by open technique, tubular, and also by endoscopic technique. And the posterior cervical discectomy and foraminectomy could be, as I mentioned, could be done by open, tubular, endoscopically, preserve the cervical motion segments, and good option for unilateral septums and decompression of the foramen secondary to the disc, because you can extend even to the foramen and remove the osseous stenotic part and relieve the compression from the root in the foramen. And also, it's required a plain and detailed CT MRI because you have many vital structure. You have to take care about it. And there is no option for indirect decompression in the cervical, so take it in your consideration. These are the different technique of the posterior cervical foraminectomy. And in the open technique, you have to do a laminectomy, aggressive soft tissue dissection, laminectomy, and foraminectomy, and also it's jeopardize the instability and neck pain. While the AO group, they published the classification and the nomenclatures of the endoscopic, and these are the technique which is called PECD, which is a posterior endoscopic cervical discectomy, and also it could be done by biportal techniques also. The posterior endoscopic cervical discectomy, it's first described by Rutin in 2007. The results with a successful rate with 93 to 97. Unilateral cervical radiculopathy with a foraminal stenosis in the unilateral septum, and lateral craniocaudal sequestrated disc also could be possible. And this technique could be done, as I mentioned, by UBE or uniportal. And the uniportal technique, the first reported into biportal technique, actually the first recorded reported in 2016. It depends on the correct triangulation of the two port, one used to introduce the endoscope, and the second for surgical instrument. And personally, I am using the uniportal because for me it's much more easier by doing it by portal. And these are the indication and contraindication of this technique. And these are the instrument that's use it. You can use the basic instrument for the spine to do this surgery. And this is the patient position. We need to do a little, let's say, flexion in order to widen the space, especially for patient with a short neck. And the most important point, that's what's called V point, which is the triangle that's defined by the upper and lower lamina toward the midline. And this is the technique that we introduced the entry point. And the entry point is depend on many pathology according to the distance between the skin to the bone. And but one concept that you have to target the V point and clear it in your initial cases. This is as I mentioned, the demonstration for the UBE, because anyone who interested, the most important is the triangulation. And these are the view of the let's say the V point in the endoscopic view, which is clearly defined and identify the root with the let's say disc that's compressed on the root. These are the MRI, and these are the post-operative result. As you see, that's complete, let's say, relief of the compression on the root. And this is the post-operative CT that show that's the hole that we created on the V-point test. These are some paper. They conclude that they show that the posterior endoscopic decompression is successful option in the treatment of the osseous cervical foraminal stenosis. You have to conclude that this the posterior endoscopically is not only for the disc but also for the foraminal stenosis, even if it is an osseous option. This is another paper that concludes that we can offer a full root decompression. It's a safe and feasible procedure, therefore it can be a good option for treatment the osseous foraminal stenosis. This is another paper that's also talking about the outcome of the foraminal stenosis in the patient. Complication, as we know that every surgery has a complication, you will not be free from it. And this include access-related neck pain, nerve injury, spinal cord injury, intraoperative bleeding, posterior epidural hematoma, dural tear, and postoperative neurological deficits when you have a high pressure irrigation. So I recommend that the pressure will be between 25 to 30. Infection is less, as we know, in this technique, and surgically induced segmental instability. I know that this is this is less compared with the other technique, but it could be an option when you do aggressive bony wall. This is a case that I presented before, and this is the surgical option that I did, actually the posterior cervical discectomy, and you see that this is the initial, and in the right view you see that's the root, and when the moment that I remove the disc and this and relief of the compression on the root. So my approach, that's unilateral endoscope using the stenotic endoscope for the cervical. I'm more comfortable with it. High speed drill, I'm using it, and also CT scan always. Ideal selection fresh with lateral disc compression, and also to keep it in mind the pressure should be between 25 to 30. Neuromonitoring, I'm not using it. I'm using it for cervical myelopathy, and when I'm doing the stenosis, the relieving of the stenosis. But here in these cases, I'm not using it. My take-home message: that's the pain is the most presenting symptom. Sagittal oblique MRI could be added value in the diagnosis. Conservative treatment, always think about it because it carry high risk, high successful rate. Plan your case in details. And the most important point, that's the ACDF and the posterior endoscopic cervical discectomy are different entity and techniques for treating the cervical spine pathology. So I don't think, from my perspective, that the posterior endoscopic fluorotomy will replace the ACDF, which is the main message from this talk. We are talking about two different techniques that deal with the two different pathology, rather than one technique will replace the others. And I will end up with this quote that we have to think about fusion, because with time we will redo the fusion, and I think that it's time to refuse to fuse. Thank you again, and if you have any question, I'm ready.